Thanks, Kaz. Thanks, Fiona. That was great. Just for those who don't know, my name is Belinda Lambros, and I'm the Infectious Diseases Liaison Nurse at Peter Mac, and a clinician researcher at the National Centre for Infections and Cancer. I have a candidacy now in antimicrobial stewardship in cancer, which is quite exciting. We're sort of coming towards the end of that. But I guess today I'm sort of going to talk about the key areas that I work with, I guess, direct patient care, but also providing education to nurses so that we do have the bedside engagement. And so I guess that's where it's around about the integrating the care. So, I guess I know I'm preaching to the choir when I say that antimicrobial stewardship and hospital acquired infections are extremely important, but I guess I wanted to put a little bit around the context in cancer. Working at Peter Mac in a tertiary cancer centre, we see so many patients here, and it's such an integral component of their cancer care, having complications in cancer. The history of cancer therapy is closely entwined with antimicrobial use, and patients receiving their cancer care, often they have prolonged and varied courses of antimicrobials, either to prevent or to treat infections, but also that because of this, their exposure to, increases the likelihood of their multi-drug resistant organism infections. Nurses know that cancer patients and their loved ones have a lot to deal with, from the worry of knowing that something isn't right to the shock of the initial diagnosis, and then the barrage of information that comes with diagnostic tests and treatment, follow-up, and so the list goes on. There's so much to take in for our patients and their families, and nurses are there to guide them as much as possible as best we can. The reality of dealing with these potential side effects, such as multi-drug resistance or infections, can often be too much to take in when they're coming to terms with what's actually going on for them right now. And so we try and take it one step at a time to ensure that they get the key messages at the appropriate time. And I guess the goal is, how do we put AMS in that for our patients? And so just in terms of antimicrobial prescribing, we know from the NAP survey that 70% of cancer patients will have an episode of an infection, and as such have a prescription for an antimicrobial at any one time. In hematological malignancies, it's 80%. In medical oncology, and radiation therapy, the incidence is around about 50%, and in surgical oncology it's between 30 and 50%, depending on the level of the complexity of their surgery. We also know that 1 in 5 patients receive inappropriate therapy related to their antimicrobial prescriptions from the NAP surveys. So it's very key for our patients. And so the AMS programs, under the fantastic leadership here at NCIC and Peter Mac, we have very good key programs, and I guess my role is really about translating the wonderful research that has been done to the bedside nurses in a way that they understand, and a way that they can implement these programs. And so the key ones, I guess, that I'll talk about today are the sepsis pathway, IV to oral switch, low-risk febrile neutropenia program, and antibiotic allergies. So with the sepsis pathway, it was initiated at Peter Mac under the leadership of Professor Karen Thursky, and it saves lives and dollars. It's a minimum of $8,000 per episode of care, but the average is around about $32,000. And the incidence of mortality was reduced by 11% when the sepsis pathway was implemented, and the time to the antibiotic delivery was halved. It's now been rolled out to 24 hospitals thanks to the Better Care Victoria grant, and should really now be considered standard of care for patients. And what it is it's a nurse-initiated bundle of care that provides a defined pathway and set of procedures to allow nurses to find early recognition and intervention when the patient's deterioration could be due to sepsis. It also provides guidance for empiric antibiotic therapy and targeting potential sources. Nurses find it empowering, and they find that it does allow them to to act quickly when they know that their patient has an infection and they're concerned about sepsis, and it allows them to use their critical thinking skills, but it also allows it to be timely, so that they can speak to the doctors quickly and get things moving, and then they find that it's a very good resource. So I guess early deterioration in the sepsis pathway is really key, but quite often we will, in patients, particularly with febrile neutropenia, there may not be that it may not be due to infection, and so we want to do a quick IV to oral switch or cease if we find that this cause of the fever was for another reason. And so if we do have, at that 48-hour mark, we would consider putting in the program, which is IV to oral switch. And it essentially is criteria-led IV to oral switch, so that the multidisciplinary team can determine appropriateness of antibiotic therapy and facilitate a timely switch to those oral medications. And the rationale of these programs is to provide patient comfort, mobility and care, and reduce IV cannulation requirements, which is always good for nurses, which again reduces related complications, costs and patient safety. And finally, it also assists in the prevention of antimicrobial resistance. So the patients that we typically look at are those patients. Essentially, the way we've got our program structured is that it is a flow chart to provide clinicians with the criteria, and it's just a common sense approach, really. It's not rocket science. It's, are they tolerating other oral medications or intake? Are they clinically improving? Do they have diagnostic tests that can guide therapy? Or is everyone scratching their heads, putting them in the too hard basket? So therefore, you should refer to infectious diseases, the experts. There are many antimicrobials which achieve that good serum concentration when taken orally, and the bioavailability of drugs listed are suitable for the IV to oral switch. And so it's about providing the nurses with that criteria to look for patients, and the quick things that we always think about are, are they stable or are they still having fevers? Do they have any micro results that should be guiding therapy? And just providing nurses with that voice of saying, hey, this is quite complex, and you've seem to have changed your antibiotic choices quite a few times and not quite sure where the source is. Maybe you should really consider speaking to ID. So it does provide the nurses with that voice. And then once they've been switched to oral antibiotics, then clearly the question may be, are they able to be cared for at home? And so we have an ambulatory program where we manage low-risk febrile neutropenic fever, neutropenic fever in the community. So essentially, there's been many guidelines and Cochrane reviews that state that it is safe for patients to have oral antibiotics while they are still neutropenic, and they can be cared for safely at home. And so I've got a couple of stories of patients that I thought might be helpful for this. Essentially, it's when patients feel well, but they're stuck in hospital due to their counts, but they're really keen to go home. And patients are obviously often the best judge of whether they feel safe to go home. There's a 47-year-old breast cancer patient who was essentially doing squats in the hallway and doing her workout while she was waiting for me to get things ready. So she was very, very keen to go home and was not going to stay in the hospital any longer than she had to. And then there was another story of a lovely young mother who had a 2-year-old, and they lived in Ballarat, but her husband and daughter were staying at apartments across the road. And so we were able to get her onto the program because she met all of the criteria in time for her to put her 2-year-old to bed that night, which is what she really wanted to do. And then once, fortunately, she did count recover because it was a couple of days to her 30th birthday. And she count recovered on the morning before her birthday. So she was able to get home to Ballarat and celebrate with her family and friends. So really, that's kind of what the program is around. And the way that we risk assess them is through the mask risk assessment tool, which is a bit of a mouthful, but essentially if patients have a fever greater than 38.3 or 2 greater than 38, they have a neutrophil count of less than 1, and the expected duration of their neutropenia is less than 7 days, then we go on to consider if they haven't been switched to orals, are they appropriate to be switched to orals? And then are they suitable to be cared for in an ambulatory environment, which is around about having those supports that they need at home. And also compliance with medical care and having that common sense approach of, knowing when to call and when to come back in, and also being close to a hospital should they need to come back in. Oh, sorry, wrong button. So essentially, as I said, I really like the patient stories around about how the quality of life is really there for these patients, but hospitals really need to know the numbers, and we save about $2,200 per day for patients on the program, and the figures, we save around about 100,000 per year on the program, having, and not only does it save those costs and allow patients to get home, but it also allows the other patients that aren't well to come in. So it assists with bed flow. And so that's where the program is been very successful. And another area that that is part of my role is antibiotic allergies. And the data that shows that 1 in 4 cancer patients have an antibiotic allergy listed, and that this would lead to adverse patient outcomes such as inappropriate prescribing, drug errors, and increased length of stay. And we also know that penicillin allergy is not forever. 50% of patients will lose their allergy after about 5 years. And many reactions that we do see are actually historical and sort of childhood in nature. And so these are prime targets to try and have their allergy reviewed so that we can get them back to more narrow spectrum. And so I guess the nursing role here, we've really highlighted under the leadership of Jason Tribbiano around getting nurses to do it upon their nursing assessment, because we are doing the administration, we're asking the patients every day, do you have any allergies? And so it's just about making sure that when we actually ask those questions, that we are finding out what the reactions are, and it allows us, to think, to sort of think smarter, not harder, and it's just that trigger point when we are admitting patients. And I'll just move on to the next one. Quite often patients will have adverse drug reactions, and it might be a side effect as well. And so we target those ones. And then the way that we have a validated tool that we use is essentially, it puts people into categories of what type of allergy it is, or is it a side effect, and then we provide education for it. So here are some of the groups. So essentially we divide them by asking several questions into, is it an immediate reaction, or is it a delayed reaction, and then is it severe or non-severe? And this is the tool that we use. And it has been a validated tool, and it is open for people to use. And there's a whole series of articles on the validation and how to potentially set up a program so that the low risk allergies can be actually sorted out at local sort of areas, because we find that only about 60% of people would have access to specialist services, such as the one that we run at Peter Mac, and quite often patients are in rural areas, and so if we can manage those local, those low risk reactions, the low risk antibiotic allergy labels at a local environment, and then only bring down the patients who really do need skin prick testing or more specialised services. It saves everybody a lot of time and can prevent antibiotic allergies continuing on for future. And so what we would do once they've been categorised into high risk or low risk, and then immediate or delayed, we would then determine which testing is appropriate for them. And the nurses really are great at doing the assessments. We know that using that validated tool, that when put in the hands of pharmacists, junior doctors, senior doctors and nurses, it actually worked the best in nurses, and pharmacists were sort of a very close second. I think it's because we do spend that time with the patients, and questions might be asked by doctors, but they tend to think about it afterwards, and then because we are there at that point of care, they might sort of mention other things to us. And I think that's why it's really good to have this tool in the nurse's hands at the bedside. And then they can obviously refer to the program, and then we would either bring them to clinic for the specialist testing or complete an oral challenge if appropriate. And we've had some great success with this program. And essentially we've delabeled about 30%, and we have lots in the system that are still coming to clinic. Obviously with cancer patients, quite often they will have steroid treatment, and so that would actually preclude them from having their treatment, from having testing at the time, and so we have to sort of schedule them into treatment breaks so that we can manage their testing appropriately. But we've had some great success, and we haven't had any reactions really. There's only been a couple of mild reactions, and so the great majority of patients will actually be delabeled in the end. And then I guess the biggest part of my role is really around about educating the nurses on all of these great programs that my consultants have developed, and making that, it's really that translation piece around utilising the sepsis pathway appropriately, considering IV to oral switch, and making it that the nurses, if they use these tools and if they have the information around about these programs, they will then, they'll end up being able to work smarter and better for their patients, not necessarily harder. And so we know that nurses are 50% of the healthcare workforce, and they are very much involved in AMS without realising it really, and it's just providing them with that information, because they take the microbiology that guides antibiotic therapy, they are administering the medications, and we also provide the education to patients and their families around infection prevention and signs and symptoms and what to look out for. So it is just over, so I will stop there. But thank you to everyone for listening, and thank you for my teams. And I think I'll hand over to see if we do have time for questions.
We do have a couple of minutes for questions. If you chat through to me, I can read them out, or you can put them into the question and answer section. Just to say, Belinda switched into a huge educational role with the COVID management at Peter Mac, and essentially established the learning programs for the PPE across the hospital. So it's been a remarkable journey for her for the last 3 months. So she's become an honorary infection prevention practitioner now. Okay. Again,
Kaz, it's Fiona. Can you hear me?
Yes.
I guess a point I'd really like to make about Belinda's presentation is, you know, thinking about the findings from the review and thinking around those issues of nurses' perceptions around workload and priorities. This really highlights, you know, putting into action these things about making information accessible to nurses, repeating education, having it fit in with their workflow. That all really comes in through that presentation. So yeah, thanks, Belinda.
Yeah, it's a great example of what we can achieve.
Absolutely.
And I think what we have is it's a unique hospital, because I think there is a very high level of literacy around antimicrobials, simply because there's just such a high amount of exposure, I think. Okay, well, thank you so much, Fiona and Belinda, for presenting this morning. And I speak on behalf of the 46 people that were watching you online. Thank you very much. And please follow through. I think Fiona's left her email, and feel free to contact us for any further issues.
Yeah.
And again, Rochelle, thanks you. I think it also challenges nurses to think of the priorities of their workflow, and these presentations have highlighted the significance of this. Thank you. Mignon, again, great presentations. And Paulo Leitao, where are you from? Tell us where you are. I'm always excited if we have international listeners. So yes, very happy to follow up with any issues that anyone would like to discuss further, and also opportunities for future research with MCAS. And I think we might finish off there. Thank you, everyone.
Thanks, Kaz. Bye.
Thanks, guys.